I'm Selma Schimmel, and we're at the ESMO Congress. It's the 35th ESMO Congress in Milan, Italy, and we are really privileged to be sitting with the president of ESMO, Professor David Kerr. How are you?
I'm well, I'm tired, but there's such momentum and buzz about the meeting. 15,000 people here, 35th birthday anniversary, having a great time. Great science, good medicine, best practice, and perhaps best of all is the fact that in addition to the 12,000 physicians we have here, we have 500 patients here also. So I think we brought the whole cancer family together, and there is no greater believer than me in the power of partnership.
Professor Kerr, this is Vital Options' 10th year at ESMO.
We're growing old together.
And what I am struck by, though, is when I began my work with ESMO, you didn't have the patient presence that you have today.
True.
And ESMO has really taken a bold step in, and let me just say for viewers, ESMO stands for the European Society for Medical Oncology, but the step that you took, a pioneering step, really was to reach out to patients and enhance this communication between patients and their doctors, which was not a common practice in Europe, but you have done enormous work here by carving out actual seminars for patients.
I think you put that rather beautifully, and I guess what we're trying to capture at the Congress is this sense of the interaction that we have as individual physicians with our patients. Everything that I do is based on, I mean this, love, not romantic love, but that sort of sense, that sort of important interaction, but truth, honesty, openness, transparency. And if I can behave in that way with you as an individual, why cannot we as a society, as a larger grouping institutionally, behave in that way for a wider group of patients and see what we can do to serve? Again, I like your sense of voice, of giving voice to those. A safe haven where they can come, where they know that the advice they'll give, the debate they'll have will be open, it will be intellectually based, it will be honest, it will be gentle and sympathetic, but it will be engaging. And creating a forum like that, you're right, people said, oh, there's risk in it, and you know, how can we have at one hand the very best science in Europe being presented, the very best science in the world, we would say, and on the other hand, you know, having patients mixed in, and doesn't that create conflicts or tension? Far, far from it. It enhances the quality of all that we do. And if we want our voice to be heard in the corridors of power, for whatever political reasons, if we unite ourselves, physician and patient, our voices together will carry far further in those corridors than individually.
Well, I would also think, as we look at global clinical trials, that by enhancing the communication between doctor and patient and giving patients a voice, that you're going to impact the enrollment in trials and greater outcomes. Yeah.
So again, let's say it again, let this be our hallmark, our battle cry, our war cry, the power of partnership. And there is no truer test of that than when we ask a patient to become enrolled in one of our clinical trials, to volunteer. So that act of volunteerism must be enhanced and made more likely if we reach out and if we're seen to be honest, decent brokers. The point's well put. And I was reflecting on this, in terms of some of the key randomised trials, the large, potentially practice-changing trials which are being presented at ESMO, they've managed to recruit over 63,000 patients. And this again is another fantastic, it's a sort of hard, subjective figure that comes out of that partnership. 63,000 patients and randomised trials being presented at this meeting.
Yesterday, thanks to ESMO, we were privileged to do a program called Advocacy in Action in association with ESMO's Cancer Patient Working Group. And I think that's pretty progressive too. What is that division of ESMO?
This is us wanting to, again, engage as fully as we can with patients, carers, their families, but also to see how we can help support each other with whatever the telling problem of the day might be, and the problems that we suffer as cancer physicians, as cancer scientists. Of course, overlap and link with those with patients, drug price, drug access, quality standards. Are there a large enough number of practicing medical oncologists in Europe? Are they well enough trained? A whole host of different issues. But one of the things that I think we're particularly good at in Europe is using our advocacy to see what we can do, not only within our own countries, not only within Europe, but in the wider world, and particularly in the developing world. Europe has, of course, strong historic, cultural, and intellectual ties with the developing world, and I would like to see our advocacy coming through to see what we in the West and in the North, in the rich and in the industrialised countries, can do to help our brothers and sisters in those low-income countries who are going to be faced with a cancer tsunami, in those countries which are least well placed to deal with it. I think together as advocates, physician, patient, carers, family, we need to start influencing the United Nations, we need to start influencing WHO, we need to become global activists, and I think our ESMO advocacy could take her into that global arena.
That you mentioned that makes me recall one of the areas of discussion yesterday that was voiced really by all the advocates at the sense of inequality or inequities between the not just countries but regions of countries with very different healthcare systems, delivery systems based in various countries.
Fascinating point, and I'm going to be a rather dry professor, and I'm going to get hung up in semantics here, so let's hope that our semantics travel. And it's the difference between variation and inequity. So I think there's nothing, I hate unfairness, so do you. And you and I would join in any battle, there we're using the war cries again, in any battle against it. And I think that if we look at the distribution of cancer resources between rich and poor, they're inequitable. I think if we look at the capacity in any country, in any healthcare system, that the wealthy, the middle class, the educated get good treatment. Poor people don't. They can't find their way into the system in the same way. They may not be funded, they may not be insured. So there's that health equity gap. I'm Scottish, you can tell by accent and by my potato-headed appearance. Okay, that's a bad joke, but that's me casting a slur in all of Scotland. This is a slur in all of Scotland, but I'm Scottish. And a couple of years ago I had to write a 20-year plan for the whole of the Scottish Health Service, and it allowed me to have an overview of my homeland, Scotland, home to many, the genesis, birthplace of many Americans, particularly in the South. And although we're all living longer and living better, the gap, the health equity gap between rich and poor is getting wider and wider in Scotland. And there are now, if we compare the best well-off with the poorest in men, the health equity gap is a loss of 13, 14, 15 years of life. Imagine that. In Scotland, you know, Scotland was at the centre of the Enlightenment. At one stage it was the sort of most literate nation in Europe, my homeland. The health equity gap, not just cancer, health equity gap, is 12 to 15 lost years of life. That's true in the States as well. It might be even more magnified. But imagine if we take that to looking at survival in the States or in the best European nations to sub-Saharan Africa. Cure rates for pediatric cancer in Los Angeles will be 80-85%. In Ghana, it's 2%. Now, this is a lost generation of children when we know we have the tools to cure them. We know we have the wherewithal, we have the doctors to do it, but we need to find a mechanism for getting that sorted out. Now, I'm now going to be a professor and talk about variation. There's always going to be some variation. All of life is determined by something we call the bell-shaped curve. So no matter what we measure, then we'll find that it's distributed in a shape like a bell. And you know, that's just true of every aspect of clinical medicine that we measure. And our job is to reduce that variability, which is a natural thing, and to shift the average up. So this is something I'm thinking about just now, and I haven't articulated it very well, but there will always be variation. There just will be, because tumours have their own biology. You're a different gender than me, you're younger than me. And you may be taking other medicines or who knows what, and that means that you and I individually will respond to treatment in a way that's different to us, and it will vary. So there's a degree of variation that is natural, that we don't understand, that we cannot conquer. But what we must do, we must stamp on and wipe out and spank the bottom of inequity and unfairness. And you can help me to do that somehow.
That would be amazing if I could
Good
help
Scout.
do that.